Good morning, everybody. Thank you for being here today. We'll go ahead and get started here. Um, Welcome to the Artificial Intelligence in Medicine and Imaging Grand Rounds. This is a monthly series hosted by the Stanford Center for AI. And this takes place on the fourth Tuesday of every month. My name is Steve. I'm a urology resident here at Stanford, currently in my sixth and final year. I spent my lab year with some of your colleagues in the center, Mirabella Rusu and Jeff Son, where we worked on AI approaches to improving live prostate cancer imaging. So a little bit more about the Grand Round series. So the purpose is to feature interdisciplinary lectures from experts in medicine, engineering, and other fields that highlight AI research being conducted in our clinical departments. It is also to share cutting edge AI research methods and their clinical applications in healthcare. And finally, we want to raise awareness of AI capabilities among clinicians. So we intend these sessions to bring together our community of clinicians and scientists who are creating new methods for the development, evaluation, and deployment of machine learning systems. We have a great lineup of speakers planned for the rest of the year, so please check back on our website soon for that info. And we'll also be sending out email notifications. Couple other announcements. We want to announce a save the date for June 1st through 5th of this year, 2026. And this is the Stanford Health AI Week. So lots of exciting events happening, including the AIMI Symposium, AIMI Pediatric Symposium, the Industry Summit, and Raise Health Symposium. So we'll announce further details soon via email and on our website, so stay tuned.
Good morning, everyone. I'm just going to get started in the interest of time. My name is Joseph Liao. I'm a urologist, a clinician in the Department of Urology. And this morning, I'm going to share with you some of the work that we've been doing over the last a few years related to developing AI technologies for the purpose of seeing bladder cancer. I see that, Steve, you're back. Is there anything that you want to wrap up?
I don't know if we got to actually introduce you, Dr. Liao, but I'll just mention he's the Catherine Simmons Stamey Professor, and he's the Vice Chair of Urology here at Stanford. I think you mentioned this, you're a physician scientist. Your primary research interests are in the development and translation of precision diagnostics for major urologic diseases, particularly bladder cancer. And he has a multidisciplinary lab. They work on advanced endoscopic imaging, image-guided surgery of bladder cancer. They use fluorescence, endomicroscopy, molecular imaging, and most recently AI. And so that's, I think, what we'll be talking about a bit more today. And all this research is funded by the NIH and also the VA department. He directs an NIH K-12 career development program for physician scientists at Stanford. And he's a graduate of Harvard College, and he earned his medical degree from Stanford, and he completed his urology residency and fellowship at UCLA. I've also had the privilege of working with Dr. Liao for the past 5 years, both clinically and in the research context. So we're excited to hear from you.
Perfect. Thanks, Steve. Well, why don't we get going? I'm going to show a lot of videos this morning, so hopefully that will be a nice complement to the cup of coffee you guys have in your hand. I obviously wish that we're together in person, but feel free to post your questions along the way, and especially towards the end. And definitely from the outset, love to say that we're very collaborative, and I very much welcome this opportunity to speak with you and hopefully make some new friends and establish new connections to push forward our research. These are my disclosures. As a clinician, I typically like to start my talk with a clinical case, just to sort of bring it all home as to why we're here. And this is a fairly typical patient case presentation of patients with bladder cancer, in which the most common presenting signs and symptoms are hematuria or having blood in the urine. And this is a 78-year-old male who presented with gross hematuria. As part of the first part of the study, he underwent a CT scan. This is obviously the coronal view and the axial view and the sagittal view. And what you can see fairly noticeably is that there is a large filling defect within the bladder. And it's relatively large, measuring about 4 to 5 centimeters. And there seems to be, in addition to this larger lesion, a smaller lesion as well. So that's fairly characteristic for somebody with bladder cancer. to have multifocal disease. One of the things that's interesting about this case is that if you were to look back into this patient's CT scan for about 5 years ago, there seems to be an outpouching of the bladder. And in fact, looks like a tumor that arose from the bladder diverticulum. So that's what the CT scan show. And as part of the workup for these patients, he was referred to our service, in which then we perform a procedure called cystoscopy, in which in the office setting, we put a flexible endoscope into this patient's bladder, and we're able to visualize a large tumor along the right side of the bladder and a smaller tumor. Patient has a kind of a standard diagnostic test is something called cytology, and we took a sample of it, and there were suspicious appearing cells within the bladder. So we have a strong suspicion that we're dealing with bladder cancer. In terms of the kind of the definitive pathological diagnosis and treatment, they undergo a procedure called transurethral resection of bladder tumor. So this is a procedure that's done in the OR, and this is a intraoperative video of what it looks like. So we take an endoscope that's inserted through the patient's urethra and all the way into the bladder. And as you can see, as we get into the bladder, this is obviously a kind of a spherical organ. And right away, you notice a couple of things. There's obviously a large tumor right in front of you. The visibility isn't really that great, and that's in part because there could be inflammation, there could be debris, and again, sort of what you saw in the upper part earlier was a tumor. And if you look around carefully, we can actually get a full endoscopy of the rest of the bladder. And we were searching for, and there it is right there. That's the other smaller tumor that was also seen on the CT scan. We have a capability, something called enhanced cystoscopy, in this case, something called blue light cystoscopy, in which we can actually turn on the fluorescence and visualize that tumor. So a quick summary of what we saw is that it's two tumors, one large, one small. So we start the process of actually then resecting this tumor. And this is done with a surgical instrument called a resectoscope, in which that we use what is called a cutting loop. And then we basically, given the relatively small size of the urethra, we have to actually cut the tumor into smaller pieces and then retrieve the fragments essentially one by one. So it's not a particularly efficient method, especially dealing with a large tumor like this. The resection itself could be straightforward for small tumors, but in this particular case is actually quite challenging given the size of it, and also these tumors can actually bleed quite a bit. So you have to both cut fairly quickly and efficiently, stop the bleeding, and keep on going. So as we continue to resect the tumor, we get down towards the base of the tumor. And as you can see here, we're getting towards the base, and you see this yellowish material, and that's actually basically that's what a fat tissue looks like, these kind of yellowish foamy tissue. Whenever we see that, we're actually quite concerned, because typically the place where you will find the fat is outside of the bladder. And because the bladder is a structure that has a epithelial lining, followed by a muscular layer and a layer of fat surrounding called the perivesical fat. So the fact that we saw the fat was actually quite concerning, and we were wondering whether we've actually gone too deep and have gone actually outside of the bladder, which is not ideal in a case such as this. As we kept on resecting, as I mentioned before, we did know that this patient had a bladder diverticulum. So most likely what we were observing was a knuckle of fat that kind of herniated into the diverticulum. And as we continue to resect the tumor in its entirety, we can see this is what the right lateral wall looks like. And this is that knuckle of fat that's kind of coming in from the outside, sneaking in inside of the bladder. And as we kind of push on it, and you can actually see the diverticulum sort of pushes itself out. So it's sort of a fairly dramatic view of a case of a tumor arising from a challenging location. Nevertheless, this is a fairly fast-paced in the OR setting. We saw a tumor that was extremely vascular. It was blue light cystoscopy positive, and suggesting that this is indeed a cancer. Just by the appearance of it and the positive cytology, this is likely a high-grade bladder cancer, and I'll get back to what that means in a bit. Aroses from a diverticulum. And then, again, we have to sort of assess, what is the depth of the invasion into the bladder wall, which is a critical determinant in the management of these patients, whether it's muscle invasive or is it really kind of versus non-muscle invasive. The treatment course is completely different for these patients. We saw the perivisceral fat, as I mentioned, were we outside of the bladder, and was there a potential bladder perforation? And also, this kind of highlights that in this type of setting, for optical imaging, intraoperative imaging, the images aren't always crisp and perfect. We're dealing with sort of real life scenarios, and our visualization certainly was suboptimal. And did we actually resect all the tumors? Were there any additional tumors that were actually, in fact, present that was not seen by our endoscopy? So the pathology for this particular patient came back to be high-grade cancer. It was TA, which means that surprisingly, this was actually localized to just the lining of the bladder and did not involve layers deeper. And then we also resected a smaller tumor that was seen as well, and that came back with a similar pathology. Sort of a quick review of the staging of bladder cancer. Again, here's the different layers of the bladder, the epithelial lining. There's a layer underneath called the lamina propria, the muscularis propria, and the perivesical fat, as I mentioned. And sort of the deeper the tumor grows, the more aggressive it is, and the management options for patients with non-muscle invasive disease, you can actually manage majority of those patients endoscopically, whereas for patients with muscle invasive disease, the primary management is actually radical cystectomy, which is the removal of the entire bladder. So an accurate clinical staging is incredibly important for these patients. That is why our guideline mandates us to actually take the patient back to the OR approximately 2 to 4 weeks after the initial resection, just to make sure that we did an adequate staging for these patients. In addition, that there were also no missing tumors. And this is important from the standpoint that you want to really embark on the correct treatment for these patients. And the first step is going to be accurate staging. And this is how the bladder looks about 4 or 5 weeks after the initial resection. As you can see, majority of which is blue light negative, but we actually did see a few additional spots that are blue light positive, suggesting that there was, in fact, residual cancer behind. So those areas were resected, and then we also took deeper resection at the prior resection bed. So what we call the repeat TURBT demonstrated residual cancer in one of the resection beds. And then the second resection bed actually did not just have the post-surgical inflammation, and we found a smaller cluster. So, and there was also, very importantly, muscularis propria, which means that we were resecting deep enough such that muscle was present in the specimen, indicating that we did an adequate job from a surgical standpoint for local staging. I was actually quite concerned that this patient may in fact have higher stage disease, and I ordered a PET CT, which did not show any disease outside of the bladder. That area of the bladder did light up, but we not uncommonly see that in the patient in a postoperative setting. So the diagnosis for this patient is high risk non-muscle invasive bladder cancer. So, I think the case sort of highlights several points that there's a real sort of a technical aspect to both the initial diagnosis and the resection of it. Our ability to see is paramount. As you can imagine, there's a subjective aspect to it, and certainly experience matters in terms of resecting these. And we're really desperate for technology that can help us see better, because again, the premise of embarking on the correct treatment for these patients is a complete resection as a starting point. So bladder cancer is probably not something that you've heard about a whole lot, and it's probably the most common cancer that you don't think about a heck of a whole lot. I guess unless you're a urologist in our field, there are about 83, 84,000 cases, new cases annually. As I mentioned, hematuria is the most common presenting signs. The risk factors are age, smoking, and environmental exposure. So very similar risk factors as lung cancer. Bladder has a very large surface area, so the thought that kind of both the duration and content of the exposure are the critical risk factors. Fortunately, most of the patients present with non-muscle invasive disease that can be managed endoscopically, but the remainder have muscle invasive or metastatic disease, of which the more aggressive treatment, including the removal of the bladder, is a primary mode of treatment. Bladder cancer does have a very, very high recurrence rate, and the reason for that is multifactorial, ranging from really kind of technical, do we see everything? Do we remove everything? All the way to something called field cancerization, in which that there could be somatic mutations present in the entirety of the urothelium, and such that you can actually have recurrence at different sites at different time points. All these factors, with a high recurrence rate and the need for a really lifelong surveillance for patients with non-muscle invasive disease, make bladder cancer to have the dubious honor being the most expensive cancer from diagnosis to death. And this is just to reiterate the point again that accurate staging is important, because the sort of your presenting staging is directly correlated with your overall survival. And this indicates that the stage of the disease and the overall 5-year survival, which for T4 disease is down to 10%, but for patients with TA disease, it's on the order of 96%. So this is a kind of a broad overview of the kind of the treatment paradigm. Hematuria, office cystoscopy, transurethral resection. If the patient has non-muscle invasive disease, then they are in this kind of a cyclical surveillance, really for the duration of their life. If the patients were to have muscle invasive disease or progress from non-muscle to muscle invasive disease, the radical cystectomy is a treatment it's the primary treatment. And there's also additional treatments for patients with both muscle invasive disease and metastatic disease with immunotherapy and chemotherapy. So the recognized shortcomings, hopefully by this time I've convinced you, is that our ability to see, the tumor morphology comes in different sizes and shapes and focality. You can have something that looks like a very typical appearing papillary tumor, all the way to something that's kind of flat appearing, such that when it's difficult to discern the tumor boundary. We emphasize that the quality of TURBT is important, such that we need to achieve complete resection, since understaging of the disease can actually have very severe sort of negative consequences. And these enhanced technologies, which I'll spend some time talking about it, are really helpful. They improve our ability to see. However, as with any technology, availability, access, whether or not they're cost effective, how do you integrate into the clinical workflow? What are some of the morbidities that are associated with these technologies need to be taken into account. Finally, as I alluded to, bladder cancer could be very much of a chronic disease. These are patients that we can be following for 3, 4, 5. I have patients over 15 years that are under surveillance in our clinic. And these patients come in with at different time points for clinic cystoscopy. They receive what is called intravesical therapy, by we can directly instill medications, immunotherapy and chemotherapy into their bladder. They not infrequently do have to go back to the OR for biopsy. So this really sort of creates a conundrum on data management. Each patient generates enormous amount of data, and how do you better visualize the information to sort of find the signal within a lot of the background noise, and to sort of plot a sort of the course of treatment is actually more challenging than it should be. we know that based on the literature, quality matters. And this is some of the classic studies that's been done to show that a TURBT in one surgeon could be very, very different in another. And the reason is not so much that there's different cancer pathology in one part of the world versus another part of the world. And studies have shown that sort of the quality of the resection is actually the main determining factor. Hence, there's been a lot of interest to develop ways to standardize the procedure, including development of a checklist. This is an example of a checklist that we use routinely in our practice that we integrated into our operative report that contains information such as number of lesions, the size of the lesion, the location of the lesion, whether this is de novo disease versus recurrent disease. What does the morphology look like? Is it a papillary structure versus something flat appearing, something called carcinoma in situ that I'll highlight a little bit more later. And being able to document that, did you visually resect the tumor to completion? Was there muscle presence in the resection bed? Was there a clinical suspicions of a microperforation? Obviously, also with that of a gross perforation. And also that we are a strong proponent of photo documentation, sort of keeping track of what's actually observed and integrate that into the chart. We're not nearly as good as our colleagues in gastroenterology, who has really, that's built it into the sort of the culture. And this is not something that is actually not routinely done by the urologist. So over the past 10 years or so, we've been doing quite a bit of work to develop ways to see the cancer better. And this is a review that we published, I think, a couple of years ago to summarize some of our findings and that of the literature. And Dr. Zhou is actually a co-author on this, what I consider as an excellent review. So just to highlight some of the technologies. So the first one is fluorescence cystoscopy or blue light cystoscopy. So this is a technology in which that the way that it works is that we actually put a imaging agent as a prodrug into the patient's bladder approximately 1 to 3 hours prior to the procedure. Then we come in with a customized endoscope, a specialized endoscope, and that basically emits blue light. And in this particular case, this patient has what is called carcinoma in situ. So it's a flat appearing tumor that if you just look at it under white light, it's actually very, very hard to tell compared to the area that contains the cancer versus not. Obviously, the area with the cancer is the part that light up under fluorescence. And this is what we call the scrape test. You can actually scrape up the lining of the urothelium. So this has been quite a useful technology that basically provide a macroscopic view and provide that contrast enhancement against the background. We've also worked on a technology called endomicroscopy, in which that we can actually take a fiber optic microscope that can be inserted through the working channel of the endoscope, and that we can actually go up with direct contact to the tumor. We can actually acquire these cross-sectional imaging of a tumor. And this is an example of a papillary tumor in which that you can actually get spatial resolution that are comparable to that of histology. So this is a kind of a live optical biopsy of the tumor itself. And we've also previously worked on molecular imaging. And this is a case where you use the cancer biology to sort of do the work for you, in which that you can tag an antibody that's cancer specific with a fluorescent tag and come in with a custom endoscope as well. So these are some of the works that have been done by us and others in the literature. And, you know, sort of the overall sense, however, is that none of these are perfect, and there are major barriers to get them into the OR on routine basis. The best example is this blue light cystoscopy that I've talked about on quite a number of times already. And there's actually level 1 evidence to indicate that the use of this technology can detect not only more tumors, but lead to decreased overall recurrence of bladder cancer. However, the uptake is relatively small around the country and really around the world, even though there's level 1 evidence supporting that, in part because of the expense that's associated with this technology, sort of the cumbersome nature to get it into the OR, and is recommended by our guidelines that it's great and you should use it if it's available, but if you don't have it, well, then that's okay. So, due to these limitations that I mentioned. So, and this is just a slide to indicate that the use of blue light can detect not only more papillary tumors, but also carcinoma in situ. And that can also have lead to changes in the risk stratifications for these patients. So just indicating that being able to see better actually we can not only do better, but has implications with respect to the overall risk for the patient. So approximately 5 years ago, we started to sort of ask the question, well, considering these shortcomings of the disease and our available way to treat these patients and diagnose these patients, and some of the limitations of the enhanced cystoscopy technologies, coupled with the challenges associated with the clinical documentation, we, like a number of other groups, begin to investigate whether we can integrate artificial intelligence into the clinical workflow for the management of bladder cancer. Specifically, can it actually improve, augment, enhance our ability to see these cancers? As many of you know, the key to developing the AI technology are severalfold. The first one is that you need to have a very robust data set, not only of the tumor itself, but also the normal or the surrounding benign lesions around the normal. So that can sort of help to train the model. Secondly, how do you present the information? As many the audience knows that this can come in a form of a classification, which means that there is a tumor within this image, to object detection, which one can put a bounding box around the region of interest with a probability score, to segmentation, in which that you can actually delineate the border of the region of interest, all the way to some of the computer vision technologies such as CycleGain, in which you can actually render digital staining to a white light image to make it appear as if it were blue light. So these are some of the different approaches that we've looked at over the years, and this was our first venture, and this is done in collaboration with Lei Singh, who has been a great partner in our journey. And this is the first generation AI model we call CystoNet, in which we train a development set of 100 patients, consists of all patients with biopsy confirmed papillary urothelial carcinoma. Given that this was our first attempt at it, we decided to pick a relatively low-hanging fruit. So these are patients with very obvious papillary tumors, all of whom have been confirmed pathologically to have bladder cancer. We trained a convolutional neural network model, and then subsequently validated in an independent validation set of 50 or so patients. This is our videos from our initial publications, fairly clunky, and this is you can see a fairly classic appearing papillary tumor in the video on the left, and this is a larger tumor. And again, this is just our just wanted to demonstrate ourselves that in a kind of a video format, our model can actually track the lesion as it kind of comes in and out of the view in the different parts of the bladder. And we were able to, in our validation set, achieve, which consists of a pretty diverse group of different grade and stage of the tumor, and achieve an overall per frame sensitivity of 90.9%, and more importantly, a per tumor sensitivity of 95%, using a normal cohort to determine the specificity. Basically, we weren't really getting a lot of false positives when applying the model to normal bladder. However, It does have considerable limitations, given that this was our initial pilot study that we've looked at only papillary urothelial cancer only. We did not look at carcinoma in situ, which is the flat lesion, or many of the lesions that are actually cancer mimicking. We were using archive videos for validations as opposed to real time, and that our output was object detection rather than segmentation. And we just specifically looked at single time point at a single center. We did, in an effort to sort of bridge the gap, manage to incorporate the model into what at the time was a gaming laptop and just sort of ask a simple question. Can we actually bring this model to the OR setting, to the clinical setting, and can we actually connect it to our live endoscopy, endoscopic surgery? And this basically shows that it is possible, and that this is sort of the surgeon's view here, and then this is actually the gaming laptop. So we can actually do some degree of real-time integration. And so that gave us some direction to move forward, which is, well, you know, we should really look at this systematically. And we set about towards these four major goals: to curate a fairly comprehensive data set, to sort of test out different models, both models that has been proven in the literature, but also any of the newer state-of-art models. We want to develop a path for real-time integration, so that this could be not just used in a in a cubicle down somewhere in our dry lab, but actually bring this to our clinic, to our OR, to get that user experience, that human interaction to the technology. And finally, once we can do that, to do a prospective study to actually validate the technology, not just at our site, but also at other sites. So this is a multi-year project that is very much ongoing. I just want to give you some of the highlights on what we've done the past couple of years. So with respect to data curation, so we've been prospectively collecting and carefully annotate patients that are both at our center. So we recruit patients not only from the Stanford Hospital, but from the VA hospital. And we have meticulously collected both images and videos, annotate them with pathology, and actually manually segment them on the region of interest by expert urologists and store them in our cloud server in a secure manner. And in part because, and this is just to mention that we have a really great diversity of both patient population and also images of the different cancer types, low-grade papillary disease, high-grade papillary disease, and we have a very robust data set of flat carcinoma in situ. These are the flat cancer lesions. But importantly, we've also curated a data set of sort of the wide spectrum of benign cancer mimicking lesions that are found in the bladder as well, and all of which are supported by pathology. So we have pathology on all of these samples. We've also curated images and videos of relevant anatomic landmarks in the bladder. Cancer is not the only disease that are found in our patients. A lot of these patients have bladder changes as a result of both aging, prostatic enlargement, chronic infection, etc. And also we have videos and images of patients, again, with basically all the common things that you can see in the bladder. We try to get a representative sample and a lot of normal mucosa as well. This is, and part of our motivation is that, in contrast to a lot of the other fields, there is an absence of publicly available data sets for bladder cancer. So we really then wanted to set about to establish a publicly available data set that's similar to the ones that are available for gastroenterology. And this is a paper that's currently under review, but sort of both the size and the diversity of our data set is very, very similar to what is available out there for GI literature and ophthalmology as well. And then we tested several representative classification learning models using our data set. And again, it compares favorably in terms of our ability to use this data set. In addition to the one that's currently under review, and this is unpublished work, we have now accumulated a pretty robust data set, not just from the 2 sites here at the VA hospital and at Stanford, but also at another institution. And again, carefully annotated and label them. And for the purpose of both prospectively train the models out under development with these proper external validation data sets. So the work that's done there is done by primarily led by Tim Lee, who's a terrific data scientist in our lab. And with respect to training of newer models, and this is the work that Liang Xu, who is a postdoc in the lab, and what Liang is doing is to really upgrade the model, which is as I mentioned, it's a CNN model, and this is the upgraded model called YOLO V11. And what Liang has been doing is to, for the pre-training stage, divide it into 2 steps. One is use really feed a model a large quantity over almost 300,000 images of unlabeled cystoscopy frames collected from 2 sites. And this is then further fine-tuned using greater than 6,000 images that are manually labeled into our newer model that we call SystemNet 2.0, with a goal to the output within a cystoscopy video stream to support clinical decision making. And with our updated model, this is what it looks like. So we can now detect not only papillary lesions that you see here. This is actually a tumor in this, 2 different tumors in the same bladder, but a patient with carcinoma in situ. And we have the ability to have the output, not just in object detection, but also segmentation, as well as in this heat map format as well. This is an example of a patient with a multifocal disease. Again, I think one of the goals is that it can help us to enumerate the number and the location of the lesions within the bladder. One of the things that we are not so much struggling, but trying to figure out the best way to present the data is that at the end of the day, the ground truth is still formed by humans, right? By urologists. So these are examples of patients with carcinoma in situ. This is a raw image, and this is the area that's segmented by expert urologists. And this is our prediction model. And as you can see, the prediction model, the segmentation of it does not fully overlap with that of the ground truth. However, it does achieve the goal of localizing the lesion. So some of the work that we're trying to figure out is, what is a true positive, what is a false positive, and what is a false positive that is still clinically useful and relevant, and how do you actually deliver the information in a way that the clinician use. So this is very much a work in progress on how to best showcase our results, and definitely an area that I would welcome any help or collaboration from those in the audience. And just to keep on going. And so a few more slides. So this is just wanted to showcase some of the integration effort that we're doing. And this is in the realm of user interface. And this is the work that, kind of a prototype of what the clinician will be seeing, in which that you can have delivering real-time information. We have a choice of picking different models. We can both record, take snapshots, short videos of the images, and then we can also do this both in offline and also in real-time setting, with the clinician actually looking at this in real time. We had a great summer student as part of the CREST program. Max Zhou worked with Calvin Zhou, who is one of our urology residents, who actually built this prototype computer that we are now testing in an OR setting that could be fully integrated with standard clinical tower. And last bit that I'll show is the data visualization, and this is also the work that's done by Kelvin. And sort of going back to what I said earlier is that we have accumulated mountain of voluminous data from all of these patients, and we have built a web portal for the purpose of data visualization. And this is a way for us to access what's available in our data set, and we can have a couple of different views. We can have sort of organize them by the type of lesion, sort of pull up all the lesions with this particular pathology, or we can have a longitudinal view in which that we can actually visualize the data for the patient, for that particular patient over time. So this is example of we call this the CystaWeb, in which that we can sort of search through the different medias that are present, and this contains not just snapshot from the clinic, but OR videos. We've also included an operative report, pathology report into the system, and that can be actually searchable. And this is that was kind of the lesion view, and this is the patient view, such that, as I mentioned, you can actually visualize the patient across the timeline of their treatment history. And what's really neat about it, that you can actually scroll through and visualize the similar area in the bladder, and then you can actually look back over time. So now we actually have the capacity to look at a region and then ask the question, this is an area that developed bladder cancer. How did that area look 6 months prior, 9 months prior? And we think this is really promising with respect to training the future model to be able to detect precancerous lesions actually before pathological confirmation. So the benefits of this type of portal, obviously, not just from a research standpoint for data set curation, but also really from a clinical standpoint to assess the patient over time, and also as a way for educational purposes, to curate a teaching library, but also retrospective review for these patients. So just to quickly summarize, that cystoscopy and TURBT are central to the diagnosis and treatment of bladder cancer. Hopefully, I provided you with some of our results that indicate that AI holds strong potential to provide clinical decision support for this important surgery that we do. And we've taken a systematic approach to curate the data, to train the models, to integrate with the eye towards clinical validation. And we've recognized throughout our journey that collaboration is absolutely the key. But again, what to do with the information, data is the king, and the validation of models are absolutely critical. But sort of what the human factor testing will look like, what the user experience and system integration are definitely important barriers that need to be overcome. And prospective validations on the horizon, and this is certainly an effort that can only be done with a multidisciplinary team. I've highlighted a couple of areas where AI, I think, is making an impact, but certainly, like many of the other diseases that I'm sure all of you study, AI could, again, help and play a strong role in helping us from a clinical standpoint. This is sort of our vision for the future, that, again, we accumulate a lot of data for these patients, imaging, pathology, genomics, liquid biopsy, and that, again, we're making, I think, the important, building the foundation towards to integrate a lot of this important data together with the help of AI. Just to sort of go back to our patients, this is somebody who was PET-CT negative, and the patient is undergoing treatment in the bladder, something called induction BCG. And I think the case is really highlights for me the importance of high quality cystoscopy and TURBT that can be complemented not just by our ability to see, but molecular urine biomarkers as well. And that will help us inform the best sort of the optimal long-term follow-up for this particular patient. Just want to end by thanking not only our patients, but the work that done by my group, that I mentioned their name throughout the presentation, but also our collaborators, Lei Singh, Tawhid Islam, or the main AI collaborators, and welcome any questions that you may have. Thanks again for your attention.
Thank you, Dr. Liao. Super interesting talk. I mean, it's a colossal effort. There's so many stages, starting from just even getting the data to executing and then bringing it to the clinic. It's a long path, and you guys have done quite a lot. We'll start the Q&A session here in the last 11 minutes, and I'll kind of just relay any questions that are answered. While we're getting new questions, I guess I'll kick it off, and I'll ask you, what would you say? Oh, here we go. We got one. Let's see. Dr. Liao, do you currently still have open postdoc positions?
Yes. We're always looking for talent. So, and I think that's really, I think what we can offer is really an environment such that you could not just be downloading a publicly available data set, right? You could be part of the data set acquisition. We can go really, really deep. And I've always invited my postdocs to come with me to the OR and the clinic. And I think that really brings it home. So we're definitely looking for motivated, smart people that can speak to, we'll teach you urology if you teach us AI. So, yeah.
So there's a lot of work ongoing like this, maybe not directly like this, but generally in AI and imaging and cancer in industry and in academia. So I wonder, what would you say the role is of this type of innovation and the pros and cons when they're conducted kind of in a private or industry setting versus academia, and is there an optimal kind of relationship between the two?
Excellent question. Certainly, I think for projects such as this to be successful, I think collaboration extends beyond just that of clinical medicine and data science. And industry partners are, I would say, absolutely essential to do this. There are things that we do well, and there are things that definitely they do much better than us. I think obviously we have access to patients. We can curate the data sets. We can set up a network to obtain these images. We know how to protect our patients. But at the end of the day, right, and we can do the testing, the pilot testing. But for this to really make it out to the real world, to actually help our patients directly, we absolutely need industry partners to help us to sort of realize that potential. We can build a prototype, but I envision then that's something that I would love to translate into an industry partner, and then to really build a device that actually robust enough to do multi-center testing. Because again, as an academic lab, we're not set up for that. So I think we can be driving the research question to make sure that the right questions are asked and protect our patients. But I think for this to really have an impact, the involvement of industry partners will be essential.
It totally makes sense. I mean, it's a very different incentive structure too between the academicians and clinicians versus the industry partners, and I think that makes a huge difference in sort of how things are prioritized. And there's a perfect phase probably in R&D and the whole pathway for when each incentive structure makes the most sense. But I would say, generally speaking, we probably are the first and foremost best advocates for the most clinically directed development first. Beyond anything, and we're advocating for our patients. So I think that's super important that we, keep a handle on these things. And as a lot of these technologies emerge, often most of the advances are maybe right now, at least in industry. But I think we all as clinicians have a duty to kind of keep up with what's going on so that we can figure out how these apply to our patients and make sure that they're being used responsibly with our patients as well. So that's
Absolutely.
why things like what Dr. Liao is doing are so important, and also just having this entire forum to raise awareness about the ongoing work within the department and other departments within Stanford is so essential. So Dr. Liao, you do a lot of work in robotic surgery as well, which is kind of a form of endoscopy. So a lot of the data you get is similar to, say cystoscopy. It's a camera, right? Any work kind of in the area of using AI and imaging for laparoscopy and robotics that you've come across that you think, I mean, I know it's a bit of a loaded question. I know there's, I'm aware of some, but if you want
Yeah.
to share some of that.
No, definitely. I think that great question, Steve. We I think we are really leaving a lot of valuable data on the table right now. And we have a great I think radiologists and pathologists are really far ahead of us with respect to organizing the data, developing a standardized format, how to store them, how to retrieve them. We accumulate and acquire this data all the time. And a lot of times they're either we don't save them or render them inaccessible. And I just think that's really doing a disservice to our patients and our trainees. And these are valuable information that can inform us about the disease process and also help us to sort of teach better. I know that we have a pretty robust platform at Stanford, this or a black box, which I think is a great starting point where we can actually all of the cases for robotic surgery. Actually, I'm not sure about laparoscopic surgery are actually then recorded and centralized in a de-identified fashion. And that could have been linked up to patients' intraoperative vital signs. Then you can also go back specifically to look at parts of the surgery. And that's sort of primarily for purposes of teaching, but also accessing. And I think that's a great start. Yeah. But there are a lot of things like how do you break up the video? How do you segment the data? How do you break it up into parts? And how do you use that information for other both teaching purposes as well. So I think that it's a starting point, and so much of what we do is visual as surgeons and as proceduralists, and I think the more that we can do to organize the data and to sort of demystify, and I see these technologies are kind of it's what it is, right? It's like the computer in the OR to sort of decode what's happening and to provide us with the tools that the next time we see this patient, next time we see this disease, we can do it that much better by leveraging the information that has been learned or seen before.
I got one more question from the audience here from Chris Holsinger. First off, great talk. Very
Thanks,
inspiring.
Chris.
Question is, how have you modified your ongoing clinical workflow to best capture these precious images and the data, and using clinical research coordinators in the clinic versus the OR, or like a postdoc or a computer scientist in the clinic?
We really try to build a model such that the OR and the clinic becomes an extension of our laboratory. And so I would say majority of my patients are all part of this study or that study or multiple studies. So we really, because you never know when the data is going to come in. So what we try to do is capture as much as possible. But in our case, we collect tissue samples, urine samples, blood samples, and also images. And obviously that does take quite a bit of a team and support. As many of us know, funding is a challenge, and how do you support these folks to acquire this type of, I think, really precious data. It's kind of up to the individual PI and a department, but certainly something that one could work together collaboratively. I think there are sort of different, obviously, avenues to explore, both from a federal funding standpoint. Philanthropy is another, and pulling together departmental resources, I think, are also just really, really important. But it's not easy, it's not cheap, and it's a fairly extensive infrastructure, Chris. But I do think that if one has the will to do it, and it's not that hard to start out. And as we've talked before, happy to sort of share with you kind of our infrastructure, and if you want to emulate or take some of what we've done, definitely happy to chat and share with you some of the barriers that we've overcome over the years.
All right. We're coming up on 9 a.m. here, and I know Dr. Liao's got to run to the operating room, which is an extension of his laboratory. So we'll close things up here now. Thank you for joining us today for grand rounds. And as a reminder to Stanford participants, you can claim CME credit for this. So text the code provided earlier to the number in the Zoom chat or follow the instructions from the email, and that'll be sent right after the session. Thank you so much, and we look forward to seeing you guys at the next session.
Thanks, everyone. Thanks again. Thanks, Steve.